Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Standard Medical Notes. So we will discuss the further topics of ECG today. So yesterday we have learnt about the chamber abnormalities. So before going on to the further topic, which is nothing but, as you can see here, it is ventricular conduction disturbances or locks. Locks. One thing I forgot to say yesterday here, see here, when there is strain pattern, the important things to remember here is there is this is strain pattern is associated with doubled infarction and stroke risk, doubled MI and stroke risk. So the strain pattern is associated with doubled MI and stroke risk. So what does that signal, what does that mean? Patient may need what do you call, stress test, okay, to know whether there is any blockage of artery, coronary artery. Treadmill test, that is nothing but, okay, or he may need angiography. These are all things we are getting realized by just knowing this strain pattern. And one thing, we can start the patient on low dose aspirin, that is nothing but 75 mg, and a statin like atorva or Rozua, Atorva 20 mg and Rozua 10 mg. So combination of low dose aspirin and statin we can start the patient on to prevent, as a primary prevention measure for cardiovascular and stroke risk. So that one thing I forgot to say. So now we will move to the today's topic, that is ventricular conduction disturbance or blocks. So as you know, if this is the heart, so this is the AV node, this is the bundle of His, and this will divide into right and left bundle branch. This left bundle branch has two parts. You can take like this: left anterior branch and left posterior branch. And right bundle branch only has one branch, one part, that is right bundle branch, single. Okay, remember this. So when we are dealing with blocks, we will try to know whether there is only left bundle branch block, left anterior fascicular block we call it as. So left anterior fascicle and left posterior fascicle. These are the two parts of left bundle. Left bundle of His has two parts, that is left anterior fascicle and left posterior fascicle. So we'll know whether there is left anterior fascicular block, or if there is left posterior fascicular block, or if there is complete right bundle branch block, or there is complete left bundle branch block, okay, or there is bifascicular block. What is bifascicular? Two fascicles are blocked simultaneously. Or there is trifascicular, all the three fascicles are blocked. So that will lead to AV block indirectly, type grade 1 AV block. So those things we will see in this block. Coming to the fascicular blocks, that is also known as hemiblocks, half blocks. Okay, so first is left anterior fascicular block, nothing but the first the left anterior fascicle of the left bundle branch is blocked. So what you will see, you will have this accentuation, this QRS duration, this is key ECG features, and these are the clinical notes on that. So I am making boxes because this is very easy to explain, and it will time will be less in explaining in boxes. So, okay, so there will be left axis deviation. When there is left anterior fascicular, there is left axis deviation, but the QRS duration will be less than 120 millisecond. And this is important. You should remember always when you are evaluating hemiblocks, so what leads you will see? You should see the inferior leads, that is nothing but 2, 3 and AVF. Okay, you should see the inferior leads. Along with inferior leads, you should see 1 and AVL. With inferior leads, you should see 1 and these are lateral leads. Okay, these are lateral leads. So these things you should see whenever there is bundle branch block. So what you will see? You will see a QR pattern, meaning there is a small Q, then a big R in AVL. Normally AVL is biphasic, remember. Okay, and there will be QR pattern in AVL, and there will be RS pattern in inferior leads. RS pattern meaning there will be a small R and big S, like this. Okay, so QR and RS pattern, QR pattern in AVL and RS pattern in inferior leads. So isolated axis deviation without QRS widening. So this will be the pattern. Okay. So when there is left posterior fascicular block, the posterior fascicle is blocked. When the posterior fascicle is blocked, there will be right axis deviation, but the QRS duration remains the same, that is left less than 120 milliseconds. Again, now this will be reversed. This will be reversed. Now you will see QR pattern in the inferior leads and RS pattern in the lateral leads. That you should remember. So when there is anterior fascicular block, there is left axis deviation. Along with left axis deviation, left axis means left leaves that thing. Along with that, QR and RS. QR pattern in left lateral leads, because it is left axis deviation, that's why left lateral leads, and RS pattern in inferior leads. But when there is posterior block, there will be right axis deviation, that's why QR pattern in the inferior leads. Because you just imagine the cameras, no, just you imagine this is AVL, here is the 2 3 AF, you just think this has 2 3 AVF, okay, and this is 1. So when there is left axis deviation, of course R should be more here, no, that's why there is QR pattern in left axis deviation in left anterior fascicular block. And when there is right axis deviation, why R should be here? R should be here actually. That's why in posterior fascicular block, because there is right axis deviation, the QR pattern will be seen in the inferior leads. Simple. Okay. So now we will see that in ECG. Already marked. See here. 1, 3 and AVF. I said in previous class, whenever there is axis deviation, you should see 1, 2, 3 AVF. These 4 leads you should see. Okay. So you can see they are leaving each other. So there is left axis deviation. There is left axis deviation and left axis deviation. So the vector is towards left side. So now R should be more in 1 and AVL. 1 and AVL. That means QR pattern should be in 1 and AVL and RS pattern should be in 2, 3F. So that we will see. Now you see the R is more in AVL and lead 1, because these are lateral leads and there is left axis deviation. So the vector should be directed towards the left side. And left side, these 1 and AVL are seeing the heart through the left side. That's why the R is more in here, in these leads. Okay. And you will see RS pattern in the inferior leads 2, 3 and AVF. So that means it is a left anterior fascicular block. So normally you can see in other ECGs also left axis deviation, but along with that left axis deviation, if you are seeing a QR and RS pattern, remember QR and RS pattern along with left or right axis deviation, that means that is hemiblock, half block, either anterior or posterior. So that's about the left axis, left anterior fascicular block. Now we'll see about the this one, left posterior. Posterior will have right axis deviation. So see here, this is predominantly negative and this is predominantly positive. This is also positive. So that is right axis deviation. Now because it is right axis deviation, it is moving away from the left side of the heart. So 1 and AVL should be negative. So you are seeing RS pattern. See, RS pattern in 1 and AVL and QR pattern in 2, 3 and AVF. That means it is left posterior fascicular block. Simple. It is left posterior fascicular block. Okay. So in anterior fascicular block, you will have left axis deviation. That's why you will have a QR pattern in 1 and AVL and RS pattern in 2, 3 and AVF. And in posterior fascicular block, you will have right axis deviation. That's why you are having a QR pattern in the 2, 3 AVF and RS pattern in the 1 and AVL leads. Okay, simple. Now we will move on forwards. Complete bundle branch blocks. So right bundle, so completely the right bundle branch is blocked. So the axis can be normal or it can be right axis deviation, but one thing you see, the QRS complexes can be either 3 small square wide or more than that, more than or equal to 3 small squares in right bundle branch block. More than or equal to 3 small squares wide QRS you will see in right bundle branch. Now, so in bundle branch blocks, what you will see is, the concept you remember, V1 and V2 are seeing the right ventricle. Okay, V1 and V2 are seeing the right ventricle, and V5 and V6 along with 1 and AVL are seeing the left ventricle. Okay, left ventricle. So any complete bundle branch block pattern, RBBB or left LBBB, will have changes in V1 and V2 along with V5, V6, 1 and AVL. That you should remember. These lists we should see. Okay. So RBBB, you will have normal right axis, and this is important. In Hemiblocks, the QRS duration was not prolonged, but you will have either equal or more than that. It is prolonged actually. QRS duration will be widened. Why it will be widened? It will be widened because there is a block, there will be delayed depolarization. So whenever there is delayed depolarization, the QRS will widen. Okay, when there is block, there is depolarization. And you will ask why that is not the case in the Hemiblock. Because in Hemiblock, if one branch is blocked, other branch is there to conduct the ventricle. That's why there is no QRS widening. But in complete block, the complete branch is blocked. So the depolarization wave has to take a walk around the ventricle. That will take time. That will prolong the QRS width. That's why in complete branch block you will have increased width of the QRS complex. That's all. Now what you will see in right bundle branch block? So you will see RSR dash pattern. So first we will see small r, big S, and then big R, like this type of pattern, RSR dash. Okay, pattern you will see in V1 and V2, and Y dash pattern in 1 AVL and V6. 1 and AVL, VF, V5, V6 you will see. Wide S, what wide S means? It will be like this in one, like this. So wide S you will see. So wide S you will see in 1 AVL, V5 and V6. Okay, that is RBBB. And remember, what is the clinical significance of that? It is often benign. It is found in many individuals, and it is isolated. Okay, it is often benign. Right bundle branch block, many normal patients can have RBB pattern. Now next thing is left bundle branch block. Left bundle branch block. So either the axis will be normal or it will be deviated to the left side, and but the QRS duration will be more than or equal to 3 small squares, means the width is increased. Now see, there will be broad and slurred R wave in 1 AVL, V5 and V6, and there will be there will be no R wave in V1, and the Q wave and S wave will merge to form a big QS pattern in the V1, and there will be no septal Q waves. Okay, so remember always RBBB is abnormal. Presence of RBB indicates abnormality, and most commonly you should exclude MI in cases of new left bundle branch block. Patients, you should exclude MI, myocardial infarction, and it suggests structural heart disease. Okay, that we will see now. Okay, we'll come to the bifascicular trifascicular. First we'll see RBB and LBBB. And see, QS may broad or slurred are in 1 AVL and V5, V6. You will have like this. This is the broad and slurred in 1 AVL, V5 and V6. Okay, you can have notch like this, M pattern like thing, but you may not have notch, but there will be broad QRS complex in these leads, and you will have a deep like this in V1. Q and S wave in, they will merge to form a QS complex, QS wave in V1. Okay, we will see that. See here. So when there is right bundle branch block, see here, there is a RSR dash pattern. This is also known as M pattern. Okay, in the V1, and in V6 you will have broad S wave. See the S wave. This yellow line represents when there is a block, and black line is normal thing. Okay, black line is normal, yellow line is abnormal, and there will be broad S wave along with increased QRS width more than 3 small squares. Okay, that is about RBBB. When there is LBBB, so see here, there is a LBBB, there is a block in the left bundle branch. So opposite you will see, this is a QS complex. Sorry, here given as RS complex, it is QS complex, and you will have a broad QRS complex in the V6. Notched, often notched. See here the notch, you can see here. See the notch. See the notch. See the notch here. Okay, this type you will have. We will see again. See here. One mnemonic I will say to remember this complete bundle branch block. I discussed the mnemonic in the topic of arrhythmias also. Okay, general considerations and mastering of arrhythmias. So remember the mnemonic Williams, W big I L A A, Williams and marrow, MARRO, marrow. This is left. LL represents left bundle branch block. Okay, left bundle branch block, and this is V1 W and this is V6 M pattern. So you will see when there is left bundle branch block, you will see M pattern in V6, W pattern in V1, means broad QRS complex, yeah, QS complex in V1, and this is left bundle branch block. This is V1 M and this is V6 W and this is RR, nothing but right bundle branch block pattern. So when there is RBBB, you will have M pattern in V1 and W pattern in V6, meaning a broad S wave in V6. So this is a simple mnemonic to remember this one, and you can see here that mnemonic also. See, this is M, this point M, okay, small and big one. And remember, in this M, the first R should be smaller than the next R. If it is like this, this is a characteristic feature of ventricular tachycardia. Okay, so it is not like this in RBBB. It is small r S and big R dash. So it is M. Okay, and similarly you can see W pattern here. This small S wave you can see take as like this downside, and big here like this. So W, small S wave, big R wave, and small Q wave and small S wave and big R wave, small Q wave, big R wave and small S wave. So this is W. The limbs of W are like this. So this is W pattern. Okay, in V6. So same is the thing for what do you call left bundle. This is left bundle Williams. This is marrow. Okay, this is Williams. See here, W pattern in this notching will give it as a W pattern. Okay, in V1, and the QRS width will be more than equal to, see here, equal to 3 small boxes. I will zoom it in. See here, approximately it is equal to 3 small squares. Okay, and in M pattern in V6, this is M, this is M, this is M. Okay, that is a simple thing you can find out. So in this ECG you can see the right bundle branch block. Okay, see here, there is a M pattern, RSR dash pattern in V1 and V2 also you can see, and in one V6 you see a broad S pattern, broad in V5 V6 broad S pattern, as well as in AVL also. This is broad S pattern, which makes the QRS equal to at least 3 small squares. Okay, this is, so right bundle branch block is there. So it can be associated with right axis deviation, no, right axis deviation, or it cannot be associated with right axis deviation. But here you can see in 1 and 3 actually it is left axis deviation, left axis deviation. Okay, and along with that you are, okay, that's all, you are having a QR type of pattern, QR. See here, QR, this is QR, and inferior leads RS, no, so this is R, small r S, but you can't see here, you can see RS, but in 2 and 3 you can't see RS pattern. So totally the criteria is not fulfilling for left anterior right axis deviation, no, so left posterior fascicular block, the totally criteria is not fulfilling. But in 3 you can see RS pattern, and in AVL, and there can be, we can say, along with RBBB there can be LPFB, but total criteria for LPFB is not fulfilled. So, but definitely there is RBBB. Okay, now coming to LBBB. See here, in LBBB left side the vector is oriented. Okay, left bundle branch block. So you see in V1 broad QS wave, this is broad QS wave, and if I zoom it in, this is approximately 3 small squares, okay, and here we can see a broad QRS pattern approximately, and it is notched, it is something like M pattern. So, and we see AVL also, here you can see M pattern, in 1 also you can see M pattern. So it is left bundle branch block complete, and along with that you can also see 1 and 3 left leaves, so left axis deviation is there, and AVF also it is negative, so left axis deviation is there. So that is complete bundle branch block, left bundle branch block. Okay, just remember Marrow and Williams. Now coming to bifascicular block. So two fascicles are blocked here in bifascicular block. So in bifascicular block, axis you can't make out, but still the QRS duration will be the width will be increased. So it can be in the form of like this: RBBB plus LAFB or LPFB. This is 1, this is 2. So this is bifascicular block. Either these two or these two. Okay, that is RBB plus LAFB or LPFB is bifascicular. Trifascicular block is rare, but you can see what is trifascicular. Again, axis will be variable. Remember, in complete branch block, axis can be deviated or it cannot be deviated. You should see the M pattern, W pattern, and in bifascicular, I will say what will be there. So here you will have a bifascicular block along with a first degree AV block. So bifascicular block with first degree AV block. What is first degree AV block? The PR interval will be prolonged. That's all, and that will be constant. That is first degree AV block. PR interval will be prolonged and it will be constant. So the term is imprecise actually. How it is it is implying as all the three fascicles are affected, but it is not the case that all the three fascicles, as I've said, I was also wrong. So it is not the case, but actually there is bifascicular block along with first degree AV block, that is known as trifascicular block. So that we will see. So first we will see the bifascicular block. So this is an ECG for bifascicular block. Okay, bifascicular block meaning RBBB. So M pattern you can see, you can make out. See here, this is M pattern. Okay, in clearly you can make it in 2, and in V6 you can see a broad S wave, V6 and V5 along with AVL, broad QRS complex. Okay, V5 and V6 you can see a broad S wave. Okay, and M pattern, RSR, M pattern meaning RSR dispersion, you can see in, you can make out clearly in V2. So that is RBBB, right bundle branch block, along with left anterior fascicular block or posterior fascicular block. So that's, for that you should see whether there is right axis deviation or left axis deviation now. So here you can see this is predominantly positive and this is predominantly negative and this is also negative. That means this is left axis deviation is there. Now we should confirm whether there is RS or QR RS pattern. So you can see in AVL QR and one QR pattern, and here in 2-3 AVF RS and inferior RS. So the criteria for left anterior fascicular block is felt. So it is RBBB plus LAFB bifascicular block. Okay, so we will calculate. So that you can see the rhythm is regular here. Rhythm is regular. Okay, and how many boxes are there? Approximately 4 boxes. So the rate will be 75 beats per minute approximately. Okay. Okay, whether it is sinus, yes, you can see the P waves are positive in 1 and 2 and they are followed by QRS complexes. It is sinus, there is left axis deviation, there is RBBB with left anterior fascicular block, left axis deviation. Okay, so we have made bifascicular block in this ECG. You don't say any chamber hypertrophy. Yes, you can't say, you can't make out any chamber hypertrophy here. Any atrial hypertrophy also you can't make. In V1 also you can't see. Okay, can't make out. You can't make out any chamber hypertrophy here. Okay, that's all. Now coming to this ECG. So this is an ECG of trifascicular block. Okay, you are directly seeing here M pattern in V1 and V2. So and here some large S wave here you can see. Okay, M pattern you are seeing in V1 A2 and large S wave you can see in V5 and V6. So it is marrow, right bundle branch block. Whether there is axis deviation, yes, this is totally positive, this is totally negative and negative. So there is left axis deviation, and you can make here QR in both 1 and AVL and RS in the inferior leads. RS in inferior. The criteria is fulfilled. This is also RBBB. This is also RBBB plus LAFB. Now we will see the rhythm. Whether the rhythm is regular? Yes, the RR intervals are regular. How many are the boxes in between them? 1, 2, 3, 4, 5, 6 boxes. So 300 by 6 box is 50 beats per minute. Okay, so it is bradycardia and it is sinus bradycardia. Okay, you can make out P wave. See here, you can make out P waves and followed by QRS complex. Rhythm strips are 2 and V1. No, you can make out P wave followed by QRS complex, P wave followed by QRS complex. Okay, but the P wave is far away from the QRS complex. That means if I zoom it, you will know this. So see here, this is the P wave and this is the distance. So approximately is 2 large boxes. So normal range is 3 to 5 small squares. How many small squares are there? 10 small squares it is. So 10 small squares meaning there is grade 1 block and it is constant. If you see the rhythm strip, it is not increasing. If you know the distance is not increased and there is no dropped beats also here, no single P wave you are finding. So that means it is what all we have find out. RBBB plus LAFB, left axis left fascicular block, along with grade 1 AV block. So that is nothing but trifascicular block. Do you see any chamber hypertrophy or strain pattern here? You can't make out any chamber hypertrophy or strain pattern. You can see this strain pattern here. See, so this is strain pattern. Strain pattern you are seeing in V1 leads. Okay, strain pattern you can make out in V1 leads. That means there can be right ventricular hypertrophy. There can be right ventricular hypertrophy. Yes, of course, R is more than S in V1 and V2. Okay, and you can't say, you are not seeing any S wave. So there probably the axis deviation is left axis, but okay. So there are two criteria for right ventricular hypertrophy. No, so axis deviation plus R more than S, axis plus R more than S. So you are having this one, but you are not having this axis deviation. Okay, you are having left axis deviation, not right axis deviation. But the second criteria says more than 6 mm small square height. So we'll see whether there is more than 6 mm small square height of the QRS complex. So one box is 5 actually, more than or equal to, no. So this is 1 again, 1 small square. So that means the QRS complex is equal to 6 mm and probably there is right ventricular hypertrophy also associated with strain pattern. So we have made many things here. So what are all the things which we have made here? We will just point out. We are having a right bundle branch block pattern. One thing, we are having a left anterior fascicular block. Second thing, we are having grade 1 AV block, and we are having right ventricular hypertrophy and along with strain pattern. So 4 things we have made it on this ECG. I think you are enjoying. These things. Okay, so that's about the conduction blocks, ventricular conduction disturbances. I think this is enough for today, and we will discuss the next topic. Okay, we will finish this also. Pre-excitation syndromes. This is also a small topic. We will finish this. So pre-excitation syndromes. What is pre-excitation syndrome? If this is the heart, this is the normal conduction pathway. So you will have an accessory pathway, additional pathway. So that is known as pre-excitation. Having an accessory pathway is pre-excitation. So that is in 2 forms. One form is, so what one thing you remember, impulse bypasses the AV node. Okay, impulse bypasses the AV nodal delay via an accessory pathway. That's why the PR interval is shortened. Okay, because AV node will put a brake to the impulse. That brake is cut out by this accessory pathway. That's why this PR interval is shortened. Okay, this WPW syndrome is a triad. There will be short PR interval less than 3 small squares, and there will be delta wave, upslurring of the QRS complex, and there will be wide QRS complex more than 3 small squares. 3 small squares. So it is a triad. What is the triad? You will have short PR interval, will have delta wave, and prolonged width of the QRS complex is increased. One more accessory pathway is there, that is known as Lown-ganong-levine syndrome. You will have just a short PR interval here. There will be no delta wave. So you differentiate this. You are having a box. In WPW syndrome, we will having a short pair interval. You are also here. Delta wave is present here. Here it is absent. QRS complex is wide here. Here it is normal. What is the accessory pathway name? It is bundle of Kent. Here it is James fiber. Remember, what is it is? It is James fiber. What are the mimics for this WPW syndrome? Mimics MI and RBBB. Whereas LGL syndrome is often benign, less likely to mimic infarction and bundle branch block. Okay, so this is benign. This is benign, but this is not benign. If you want to know how it is not benign, you go and watch the videos of arrhythmias. Very detail I have discussed in that. So these are the two ECGs. Okay, so you see this rhythm strip, second strip and V1 strip are known as with rhythm strip. Whenever you are assessing a rhythm, you should see 2 and V1. You can see a short PR interval along with slurring, and width of the QRS complex is prolonged, which is more than 3 small squares. If you are not able to make out, I will zoom this. See here. If you take this as the marking, very much you can't make out 1 or 2 just small squares are there. So the PR is shortened. Okay. Now we'll take this. If this you take this one, because you consider this as baseline. Okay. From here to here, how many boxes are there? Approximately 3 to 4 small squares are there. So that means the width of the QRS complex is also increased, and you are having a slurring upside. So that is delta wave. So this is a pre-excitation pattern which you are seeing. Okay, and same thing you can see in V1 also, and along with that you are seeing strain pattern also in V1. See here, this is the strain pattern. Okay, so this is one, and you can cut this one. There are only two small squares, so less than 3 it is. So PR interval is shortened. Okay, and there is delta wave, and QRS complex is up to here it is 4 small squares, so it is prolonged. So here you can see the strain pattern. Strain pattern is there, and R is more than S. Now we'll see whether there is axis deviation. Yes, there is axis deviation. Sorry. See, there is right axis deviation. So right axis deviation along with R more than S and strain pattern, that signifies there is also right ventricular hypertrophy with strain pattern. The criteria is fulfilled. Okay, there is right axis deviation also. So we have seen these things in this ECG. What is the heart rate in this ECG? So it is 4, approximately 75 beats per minute, and it is regular. It is in regular rhythm. It is sinus rhythm, sinus regular rhythm. Okay, that's all. Now we'll see this ECG. So see the second, very sorry, second and V1. You can see short PR interval. You can see short PR interval, but you can't make out any slurring of R wave here. So, and you can't make out the QRS complex is less than 3 small squares. So it is Lown LGL syndrome. Levy's, what the name is? Lown-ganong-levine syndrome. Lown-ganong-levine syndrome. LGL syndrome. Lown-ganong-levine syndrome. Okay. So can you make anything else here? Anything else here? Anything else? Anything else? Whether it is left ventricular hypertrophy, V1 plus V5 V6, no, you can't make out. Cornell criteria, no Cornell criteria, AVL and V3. And also there is no axis deviation. That's all. There is no axis deviation. There is nothing. It is regular. Everything is normal. Just there is shortened PR interval because of that James branch, James fiber, James bundle branch. Okay. So this is today's topic. I think you are enjoying, and I am also enjoying. So the next topic will be acute coronary syndrome. Very important, MI. We'll discuss in the next video. Thank you for watching.